All. This is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. Today, once again, we have a rock star with us. We have Dr. Bruce Patterson with us from Incel. And today we're going to talk about exclusively about the long haulers. So Dr. Patterson and his team has been working on the long haulers, their symptomatology, their immune models. Then there is a test panel that he has figured out that would allow us to know more. And then, of course, the most important thing is how do we figure out how to treat the long haulers? So I think that this is an area where this is an underserved area. The COVID itself has been pretty damaging, but there is a large population that is now in a long hauling state, and there is nowhere some care for them. I was listening to a person's interview this morning, and she was saying that for 9 months, I've seen 52 doctors, and I have no idea how would I find a solution. So here we have a hope here in Dr. Bruce Patterson and his team. So Dr. Patterson, welcome.
Thank you, Dr. Bean. It's a pleasure to be back on the show.
Excellent. So just once again, for the benefit of the new users, a little bit of introduction about yourself, and then we'll talk about long haulers.
Yeah, sure. I'm a trained pathologist. I did a postdoc in molecular virology. This was all happening in the late 80s and early 90s during the HIV pandemic. So a lot of this is common. I see some of the same scenarios going on in COVID as I saw in HIV, in terms of trying to figure out how do we detect this, how do we monitor this, how do we manage it, how do we treat it, what's the etiology at the bottom of all this. And so again, I think one of the advantages I have is to follow that pathway in terms of investigation to get to a successful place where we can actually treat both COVID and actually treat the long haulers who, if you've heard all the stories that I've heard over the last 4 or 5 months from the hundreds who have participated in this study that we're doing and participated in everything that we've been trying to do in terms of treatment, it's heart-wrenching. And they are facing some of the same stigma that people in other pandemics have, where the physicians, don't listen to what symptoms they're having, or they try and attribute it quickly to something else, or it's not real, or I don't know what to do. And that's, again, it wasn't successful in the 90s. It's not successful now. So we thought 4 years ago, we really need to get to the bottom of this. Number one, we need to understand it. And then number two, once we understand it, we can start rationally treating the long hauler syndrome, which, like I'll talk about through our bioinformatics and AI, is a distinctly different immunologic entity than active COVID, either mild to moderate, severe, critical, what have you. It's a completely separate immunologic condition than active COVID.
Absolutely. And so on that note, let's start with this, that what is the symptoms that you have been seeing? I have been seeing in my long hauling patients symptoms of various kinds. They come and they go away and then they come back again. So what is your study so far?
I agree. I think when we first started looking at long haulers, I thought it was very heterogeneous. And in fact, the presentation is very, very heterogeneous. And at the end of the day, the etiology could be heterogeneous, although I think there's now recurring themes. What really surprised us, which was the heart of this paper we submitted last week, is the fact that we found an immune signature by, like I said, using machine learning and bioinformatics and AI to look deeper into the immunology. We found a signature that's common in all of these patients, when in fact everything else around them is different symptoms, different combinations of symptoms, different immunologies on top of the signature that we saw that are causing symptoms. And one of the things we're doing now is trying to wrap our hands around, which of these immune markers are causing what symptoms. So again, we can more rationally treat these individuals.
Got it. And talking about the immune markers, so I think that is the meat of the whole discussion, that there is something that you have found that I think the rest of the world yet is waiting to understand. Tell us a little bit about the immune panel. What dysregulations have you seen? What are your hypotheses for what's going on?
Well, again, I think when we started working in COVID many months ago, we started with an enormous panel where we were looking at hundreds of different hematology and immunology and molecular biomarkers. And I think after looking at over 500 patients and numerous different trials and arenas, I mean, we've come to figure out exactly what molecules really mean something and which ones don't. And so we've narrowed that panel significantly, and we've narrowed it to one that we can launch with laboratory partners so that this can be run routinely on patients' blood. And again, having that at our disposal and what we now call in our paper a long hauler index, or a score essentially that sums up the common immunologic markers that we're seeing in all these individuals, and creating a score that we can track following therapy is something that's much needed. Because if you're going to look at individual symptoms, what are you going to track? I mean, I'll tell you the first figure from our paper, and excuse me, but I'll actually read these off because I have percentages of the over 100 patients we've looked at. But for instance, fatigue, 33%. I think most people think fatigue affects everybody, but in fact, in what we've seen so far, that's about 33%. Myalgias or muscle pain, 20%. Chills, 5%. Brain fog, 30%. Arthralgias or joint pain, 13%. Burning sensations, 11%, and I'll get back to that in a minute. Temperature sensitivity, 3%. Chest pain, 10%. Tachycardia or increased heart rate, 18%. Cough, 12%. Shortness of breath, 28%, which is very interesting since that's one of the obviously the important symptoms in active COVID. Neuropathy in 20%, and again, we're starting to get our hands around that from a marker standpoint. Rash, 4%. Gastrointestinal symptoms, 10%. Insomnia, 8%. And loss of taste or smell in about 5%, where it really hasn't come back. So that's sort of the symptom spectrum that we've seen, and it's the first figure in our new paper, but it's highly variable. So coming up with something, a score that is measurable and quantitative across this disease spectrum, I think was very important in terms of moving forward with therapies and monitoring that.
Got it. So I heard that you have a paper that is about to be published or has been submitted. Can you tell us a little bit about that paper? Well, if it is okay to talk about it before it is published.
I think it's more important to disseminate the information. And again, it's been several papers. There's one that just came out, like I said, that has really opened our eyes in terms of the long hauler data. But it was a paper that we that got accepted last week, where we had a patient in collaboration with Washington University in St. Louis and Phil Mudd, that showed an individual that had COVID RNA, detectable COVID RNA, out to 87 days with no period where there was undetectable virus, which is quite unusual. During natural history of COVID, I think viral loads, as we reported in this paper, despite therapy or in the absence of therapy, pretty much by day 28, viral loads were undetectable in nasal swabs. But this was an individual who never went to undetectable and had detectable viral RNA out to 87 days. What was very interesting about this individual was the low CD8%. And again, that was a common finding in the paper that we also got published in early November, which was from the early days in March. One of the hallmarks of severe to critical COVID was this very low CD8 percentage, which is the opposite of what you see in HIV, which has low CD4% and low CD4 counts. We're seeing, but the two work in tandem to create a competent cellular immune response. And so what we were seeing was very low CD8 percentages. And in fact, the CD8 percentage never really increased in this individual over the course of these 87 days where viral RNA was detected. Now, what's very interesting in going back and looking at the long hauler data, for the most part, the average CD8 percentage in the 100 plus long haulers that we've looked at is within normal range when we compared it to 30 plus normal individuals. But what was interesting is 25% of the long haulers in our study had low CD8, which fits with this paper that was just published, suggesting that this could be persistent COVID. And we're not necessarily saying persistent replicating COVID, although it could be low levels, but we're saying COVID RNA, maybe COVID protein that is still in antigen presenting cells or other long-lived cells. And in fact, 25% of patients, long haulers, who are months and months and months post-COVID, still having CD8 percentages in the 10 to 20% range when normal is 30, was very surprising when I looked at the long hauler data after our paper came out a week ago on this individual.
Very interesting. So if I sum it up for the cool beans here, what you're seeing is a reduction in the cytotoxic T cells and a possibility of the viral debris or viral RNA sitting around or some. So talking about this, because here in the cool beans discussions, we've been talking about the reasons for the long hauling, and we've been hypothesizing that what could be there. For example, I've been discussing that there is a possibility of the organ damage, and that organ damage lingers on and recovers for some time. So that is one reason for some symptoms to continue. But then there is a possibility of immune dysregulation. And then finally, there is a possibility of the virus debris just sitting out there and poking the immune system again and again. What have you seen in terms of pathophysiology, in terms of the internal mechanisms? What is going on?
It's a great question, and again, there's been so many theories out there, and I never shut off any thoughts because, like I said, learning from several pandemics, there's no doubt there's been surprises. By the same token, in looking at pandemics, I remember in the early days of HIV, there was a distinct group of scientists who thought that the CD4 depletion was not due to HIV. And they started proposing all kinds of other theories, super antigen destruction of CD4 and everything under the sun. And when in fact, if you looked for the right thing, you found it. And we were part of the group that found HIV and CD4s, and we're able to, in the early 90s, and other groups are finding HIV in plasma, and we were able to link the virus to the pathogenesis, meaning we were able to link the virus to the immune destruction. I mean, similarly here, we're seeing a immune profile that I would describe as very appropriate. I've told a lot of people, and I think others now are agreeing in the literature, that the immune profile in active COVID was chaotic and disorganized, and there was many abnormalities, as we described, and others, and people are digging deep into that. Conversely, what we're seeing in long haulers is something that looks very appropriate, as if there is persistent antigenemia of some sort. Is that actually COVID? This is a question I asked myself, 3-4 weeks ago. Is it actually COVID, or is it some of the persistent viral infections that we all know of? Epstein-Barr, cytomegalovirus, human herpes virus, herpes simplex, varicella, which is chickenpox and shingles. Are these some of the agents that are part of the pathogenesis? And you know what? The fact is, they still could be, because if you have long haulers who have low CD8s, their ability to fight off other viral infections or clear appropriately COVID is compromised. So to some extent, but those were all the premises we went on. And then once we started looking, for instance, we started looking for CMV and EBV, and some of those studies are still ongoing. And but what we did find was COVID protein in a very important cell type in the monocytic lineage. So in our white blood cells that float around in our blood, there's lymphocytes, there's monocytes, and there's neutrophils. Neutrophils are involved in fighting off bacteria. Again, I'm hopelessly generalizing. Lymphocytes, of course, viral infections, and monocytes, other infections, including viral infections. But it's this monocyte lineage, which they act typically as antigen-presenting cells, which basically gobble up viruses and present their proteins to the immune system at large, as well as dendritic cells and others do the same type of thing. But there's a cell type that's interested me since the HIV days, and it's the CD14 positive, CD16 monocytes. And this is a pro-inflammatory monocyte, which again tipped me off because a lot of the long haulers still have elevated interleukin 8. Interleukin 6. They still have, all of a sudden, elevated interleukin 2, elevated interferon gamma, elevated VEGF, elevated RANTES. And I think this is part of these pro-inflammatory cells still making all the molecules that we initially saw in active COVID, but in a different combination, if you will. For instance, in active COVID, IL-2 and interferon gamma I found were surprisingly low given a viral infection. And then all of a sudden in long haulers, it's interleukin 2 and interferon gamma are significantly elevated. And I think that's part of the hallmark of the long hauler index, as well as other markers. But all of that is pointing to persistent, some sort of persistent antigen, presumably viral antigen. And again, we found COVID antigen in this CD14 positive, CD16 monocyte. We haven't published that yet, but we saw that in severe to critical patients, and we've seen it in a few long haulers. And again, by no means have we found the etiology to be as consistent and reproducible as the long hauler index and the elements of the immune system that make up the long hauler index. However, we found a long-lived antigen presenting cell that happens to be pro-inflammatory that still has COVID in it. And I think that's the start of something that will lead us to rational and effective therapies.
Wow, so this is very, very interesting. I had actually during my discussions never thought about monocyte keeping the antigen in them and just running around with it and then causing inflammation. So it seems like you have a very deep understanding at this time from the studies of the long haulers, the type of symptoms, the variations in them, the kind of immune possibilities that may be causing the issue. For example, maybe the virus itself is persisting, or some part of it is persisting in some cells, and that is causing the immune system to just keep going nuts and keep causing inflammation. The bigger question now, is there hope for long haulers? Have you suggested some therapies? Have you tried some therapy? What is happening in terms of offering a healing touch to these folks? They're quite desperate at this time.
You're absolutely right. And again, that's really the name of the game. I can sit here and pontificate about, all the immunologic findings and, for days. But at the end of all this, the goal is really to have a rational approach to therapy. I mean, a lot of times we have this tendency to throw something against the wall and say, is it going to stick? And I think these profiles that we've seen, these patterns that we've seen, have really led us to at least take a more rational approach. Have we found the magic bullet that works for everybody and our job is done? No. And it may be quite some time before that actually happens. But, the good news is we have treated 20 or more patients based on the information that we've been able to glean. And, like I said, we haven't had that aha moment where, somebody is back to normal and they're out 2 months and they're still feeling perfect, nor should we expect that. But we are seeing success, and we're seeing success with a variety of different agents. And I think, maybe that's just an indication that the etiology of this very consistent immune pattern can be different in different individuals. We've had individuals who respond to ivermectin. We've had individuals who have responded to high-dose steroids, low-dose steroids. We've also had individuals who are responding to Maraviroc, a CCR5 antagonist that based on the fact that they still have elevated RANTES in a good proportion of them. So we have seen success, and we've also seen individuals who feel great for a week and their symptoms start to come back. I wouldn't, think, they're not coming back maybe to the same extent, but they're coming back. And so right now we have a battery of agents that we know has worked in long haulers. And now we're trying to decide exactly how long do they need therapy. I think that is a critical decision, because I think that's something that has stuck with me since looking at active COVID. Are we under treating these individuals? We're getting them out of the hospital, and obviously they're getting back to their homes. But are they really better? Or could they have benefited, for instance, like in the leronlimab trials and now in the Maraviroc trials? Could they benefit from another week, another 2 weeks of therapy? And and then the big question arises: what can we do going forward to keep individuals from becoming a long hauler? And I think we're starting to figure out what that may be. That may be the fact that we're incompletely treating when they have COVID. We're rushing them out of the hospital because we all know that's not the best place to be in terms of infections and otherwise. But so once they get up, over the hump, they're going home. But do they need therapy, out the door where you can ensure that maybe their CD8 percentages are back to normal before you take them off therapy? Maybe other markers like RANTES and IL-6 are back to normal before you take them off therapy. All of these, I think, are critical points that we're looking at right now, because I'm really thinking that there's a reason why they became long haulers. Again, this patient out to 87 days seems to be maybe incompletely treated. So as we have more drugs in our armamentarium, antivirals, immune modulators, immunosuppressants. I think we have to think about, when do we start treatment, when do we stop treatment, and what can we do when long haulers come to our office. All of those are still in play, vaccine or no vaccine. We're still going to have to treat patients. And if it's true that 10 to 30% of COVID infected individuals are now long haulers, maybe even more that in the severe category that were hospitalized, that's a lot of patients, and that's a lot of patients to manage over the course of the next year or two, and while we're figuring out exactly how to treat them. I mean, at the end of the day, one would think that immune tolerance kicks in at some point, and despite the fact that you have this antigen around, your body tolerizes to that, and the inflammation, wanes just naturally. Obviously, the symptoms that we've seen, the symptoms that we've heard of, the patient stories that we heard of, like I said, are heart-wrenching, and we can't get them better faster in our mind, and obviously in their mind. So these are all the things that are in play for us right now.
Got it. So I have one more question before we go to the user comments here as well. By the way, Dr. Yo is trolling us here. He's saying, is that big giant incel sign behind Dr. Patterson? Is that a plush pillow?
I wish. It's not. It's just a sign. So
okay, so no sleeping in the office.
I wish it was a pillow.
So then I have one more question, and that is more focused from the long haulers that are in the Cool Bean group. Mm-hmm. How do they find help? Where do they go? What do they say? Is there some affiliation, associations of your network? Where do we go? If I have become a long hauler, how do I get help?
That's a great question. And again, we've been working day and night to get basically our program scaled, commercialized, et cetera, where, the labs are ready. We're ready. We have a great physician network, and Dr. Yo has been amazing at putting together a network of physicians around the country that will be part of a group where we'll be interpreting the laboratory data. We'll be making recommendations on therapies, and physicians across the country that are in our network will be instituting therapy and monitoring therapy. We're very close to getting that already. There's a lot of moving parts. I think the most important thing was to understand the disease, also to understand our armamentarium of therapies that are in our grasp right now, and how patients are responding to those. I think that was a very important first step. And but all the other workings are going on actively day and night to get the testing labs up and going and CLIA certified, and so that they can run the patient samples day and night, and as this long hauler cohort grows. And then we'll be launching a website probably in the next week or so that will have all the information that you just described: where to get the testing, where to get treatment, where to, FAQs, the latest and greatest from the lab bench, a site where long haulers can communicate with one another, ask questions like they're doing on the side of our computer right now, but do it in an open forum and get those answered in a timely manner. I think, like I said, all of that is going to be coordinated by a website, and again, I think it, as soon as the first of the year rolls around, that all should be live.
Excellent. So that is a great hope. So what I would promise to the cool beans over here is that as soon as your that service has launched, we would get back to the cool beans and we'll share this website. And if possible, Dr. Patterson or Dr. Yo or somebody from your team can come in and give us some instructions as well for how to reach out to you, and then move forward from there. And just for a full disclosure, because these videos are finally going to be watched by our audience on our site as well, I do not have any financial or other interest in it. My biggest interest right now is to bring these information to the patients and to the providers so they can know where to refer their patients to who need desperate help. My worry is that this pandemic after vaccine probably is going to start calming down, but the epidemic of the long haulers is going to stay with us for a long time. And as Dr. Patterson said in the beginning, the torture there is that not only they are going through these symptoms, but doctors do not know what to do. And the worst part is when they say this may be psychosomatic or this may be psychological, and that is the torturing part.
It's horrible. And you know what? I've seen it over 25 years in medicine. I've seen it a number of times. If you can't explain it, it's psychosomatic. I mean, we saw it. My first dose of that was in the early 90s during the AIDS epidemic. There was also essentially an epidemic of chronic fatigue syndrome. Everybody had chronic fatigue syndrome, and nobody could find an etiology for chronic fatigue, so they brushed it off. A lot of it was caused by Epstein-Barr, but sometimes they couldn't find Epstein-Barr, so it must be something different. And then paradoxically, chronic fatigue resulted in insomnia. So you're getting these sleep clinics in the 90s were packed with people who had chronic fatigue. They couldn't sleep. How awful is feeling beyond fatigued and then not being able to sleep? And again, then they found CMV, or cytomegalovirus, which is common in immune suppressed individuals, but it's also ubiquitous out there in the world. I mean, 1 out of 3 of us probably has CMV DNA in our blood somewhere, and in fact, when in its worst case, can cause chronic fatigue. And there was a great clinic at Stanford that looked at that specifically and treated it, and got these people over the hump. But they were disregarded as well. Then the next big one that was I thought really underestimated was fibromyalgia. A lot of people have fibromyalgia symptoms. They, joint pain, muscle pain, or I just in general don't feel well. Again, very quickly they were thrown into the psychosomatic category, when in fact now we recognize fibromyalgia and there's actually drugs to treat it. So, the list goes on and on and on, but we don't want long haulers to become one of these lists where they're just ignored and then brushed off as being, malingers or psychosomatic.
Got it. Thank you very much for all of this. So just to put a bow on the discussion so far, for those who joined later, long hauling, Dr. Bruce Patterson and his team has been working on it. They have been treating some patients. They have been assessing some patients who are long haulers, and their immune panels is being seen, their symptoms are being seen. So there's a lot of study that has happened, and now Dr. Patterson and his team is gearing up to start offering a service to help long haulers as well. So if Dr. Patterson, if you have a few more minutes, there are tons of questions, but I want to take some questions from the community as well.
Sure. Yeah.
So one question that I saw very frequently here was about the vitamin D deficiency or B1 deficiency or magnesium deficiency. So have you seen any such things as well?
Again, you know what? We don't really, we don't measure those. So I'm not going to say yes or no, whether or not they're involved. I think, you know, it's the immune profile that has really struck me. And I'm sure these individuals, because of their symptoms and because of, you know, COVID itself and what they've gone through, I'm sure they have a smattering of other deficiencies that, you know, that also exist. It's using experience to kind of put together a rational pathogenesis. And being a pathologist, that's all we think about is what is the mechanism behind a finding, and you know, until you really identify a mechanism, it's really hard to say whether something's involved or not involved. And everybody, you know, I think in general, it's human nature to kind of look for that universal, you know, theme of disease, and when in fact it's there's subtleties in every disease that are different from patient to patient. So I don't rule anything out. For right now, I know what we see, and I have a really good idea of what's going on, and you know, we're looking and we're treating.
Excellent. So just one comment here, which is very interesting. Jana has been a cool bean for some time, and check her message. Fishing a doctor that understands immune system is like finding one that understands hormones. I've been to too many to count.
Yeah.
And I think this is what do you think?
You know, it's absolutely true. You know, it's very, you know, it's very difficult these days. Because you have physicians, you have insurance companies, you have all these things, you know, weighing in, and then medicine has become so subspecialized, and you know, and then physicians tend to think within their subspecialty or their specialty, and you know, it's again, I always find pathology very interesting because it was really at the end of the day, you know, whether it's a surgical specimen or a tube that went to the lab, it was our job to kind of diagnose what was going on and figure things out from multiple different inputs. You know, you get inputs from the people looking at a slide, you get inputs from people, you know, running blood chemistry, blood hematology, virology, immunology, and then you had to consolidate all that information and come up with a disease, more or less. But the first thing you had to do is come up with a mechanism. And the one thing we learned in pathology is there's so many red herrings that they're just there. They, you know, everyone tries this unifying hypothesis. I want to take everything that's abnormal and put it together into one package, and that's what it is. When in fact, like I said, there may be red herrings. This may be abnormal, may have to do with something completely different. So that's how we're looking at this, and we're trying to put the puzzle together. But if there's some extra pieces, then you have to say, do they come or do they go? So I think it's really important.
Got it. So a question here from Dean Clayton. Question: please talk about the burning symptoms you briefly mentioned.
Yes, thank you for that question, because I think it gets us back to this topic that we're actively looking at, which is now we have, you know, hundreds of individuals. We have all these different symptoms. We're now starting some projects with some collaborators trying to put the symptoms together with either immunologic patterns or different immune abnormalities themselves. For instance, here's a good example: VEGF, vascular epithelial growth factor. What are the two symptoms that I commonly see when I see elevated VEGF, which is actually fairly common in a cheat sheet, fairly common in long haulers, and the two things that it does is it causes increased blood vessel growth, and it causes peripheral neuropathy. So when you talk about numbness, tingling, burning sensations, which could either be vasodilatation or potentially a neuropathy of some type, one of the major things that sticks out is VEGF, or vascular endothelial growth factor. When you talk about joint and muscle pain, IL-6, IL-8, those are common to the arthritis folks. So that's what we're doing right now, is we're trying to tie in many of the immunologic abnormalities with the symptoms. And then when we can do that, when we look at the immune panel and we know they have a certain symptom, then you can start saying, well, is that symptom going away with therapy? Well, I saw that your VEGF went down. Did the burning sensation go away? Did the neuropathy go away? We all know that neuropathies might take some time to go away. Peripheral neuropathies classically will go away. They're reversible. And again, that's another message to the long haulers. A lot of the things that you're feeling are reversible. So you are not necessarily scarred for life. There is hope at the end of the tunnel. But, again, relating the symptoms to certain diagnostic parameters, I think, is really key, because that'll help guide therapy ultimately with the long hauler index.
Got it. So while we look at this question, I want to ask you one more question before. Some of the folks are asking, is there a place for leronlimab or for ivermectin-like things? So we'll go to this question as well, but your quick comments about leronlimab or ivermectin or any other therapy that is known that may help?
Well, again, from the last 4 months, I'm now convinced that it may not be just one therapy. Like I said, ivermectin's worked with some individuals. I would say, steroids, the low dose steroids, 10 milligrams per week, 10 milligrams for 2 weeks, something along the lines of asthma therapy is probably best in terms of relieving symptoms. And the reason it's better than some of these high dose tapers is 60 milligrams of prednisone is making individuals, just bonkers from steroid symptoms. So they don't know, is this a steroid symptom? Is this part of my long hauler complex of symptoms? Is it getting better? Is it getting worse? I don't know, because, I feel so weird. So, these things where you start at 60 milligrams of prednisone and taper down over a week, I don't think that's effective. A great immunologist that I knew at Northwestern, Dr. Patterson, not me, he was the one who came up with using 5 milligrams of prednisone for asthma. Now we have great drugs that are very specific and not quite so non-specific as steroids, but he used it safely. There was no side effects at that low of a dose, and people responded magnificently. So I do think low dose steroids over a long period of time is going to be a very effective therapy for long haulers. Ivermectin, potentially, if it's still a virus, if it's one of the herpes viruses, maybe acyclovir. If it's CMV, maybe ganciclovir. I mean, I think as we start to pull in more and more information about what the etiology is, we'll start to come up with more rational approaches. And indeed, Rantes is elevated in individuals. So CCR5 blockade with Maravirac or leronlimab, when it gets approved, is probably part of the therapy, is part of the, the armamentarium we have. Is there going to be a magic bullet? I really don't think so. I think people are going to respond to different modalities.
Got it. And just for more color on the steroid side, for 5-6 months now, whenever I have been managing my patients and they become long haulers, I usually give them 5 milligram delta cortrel morning, evening, morning, lunch, evening, so 15 milligram total, and for a few days, and then I taper it off. And I have seen only in one case I had to give it twice. Otherwise, usually it works fine. So that is what I've been pushing as well, to say we should do it. And another interesting thing that I saw, I thought this was a scary or a dangerous practice, but in my country of origin, what they do is over there, right from the very first day when they start treating, they start giving delta cortrel with it. And I thought that that would cause immunosuppression and the virus would now go rampant, as we have some studies as well. And that would actually be more counterproductive. But what I'm seeing is that all those new set of patients who have so far talked with me as well, because if they started becoming deteriorated, and if they were already on steroids, none of them becomes a long hauler. That is a very strange observation that I had.
Yeah, I mean, which would support this antigen hypothesis. And again, I'm fearful. I know everyone's doing it right now. I am somewhat fearful of giving immunosuppressants while there's still active viral replication. Again, I think if it potentially, the thing about viruses that I've realized is they love activated immune cells. A cell that's activated, expressing a variety of different receptors on the surface. Like, for instance, this monocyte, we found out that it had the highest levels of CCR5, and it was the monocyte, the long-lived monocytic reservoir for HIV. We published a paper in 2009 about this cell expressing CD81, the putative receptor of hepatitis C, and in fact, they were infected by hepatitis C. I heard from others that it may also, these quote monocytes may also be infectable by influenza. It's almost as if it's the body's garbage can for viruses, and probably for a very important reason, because it's an antigen presenting cell. But I think strategies that reduce the viral reservoirs early are going to be ones that ultimately will prevent long haulers.
Got it. So some more questions, and please just let me know when your time. I know it is late. So Kevin's question is: some of the long haulers' heterogeneity possibly the result of a variety of previous exposures to other viruses in life, and due to all the resulting immune system retunings?
I mean, I think that's moving in the right direction. I think, herpes simplex is ubiquitous. By the time you're 60 years old, I think 85% of the population has HSV antibodies. So you have herpes, like I said, you have varicella, you have EBV, you have cytomegalovirus. They're all ubiquitous. And I think, long haulers are all different, and they all have different exposures over the course of their lives. And absolutely, these could be involved. I mean, if your CD8 count goes down to the levels it goes down to during active COVID, I wouldn't be surprised at all that you wouldn't get reactivation of herpes, reactivation of varicella, reactivation of CMV. Again, one of the other things we see in long haulers is increased B cells. That's Epstein-Barr's favorite reservoir. So it's such a great question, and the answer is, yeah, absolutely it can play a role. That's why I think there's not going to be one single treatment that's going to work for everybody. It may be antivirals plus immunosuppression. It may be just immunosuppression. It may be, it may be other, other treatments that we don't know of yet. But the fact is, we have the capabilities of looking at people on an individual to individual basis, so-called precision medicine, with our new panel, coming up with a long hauler index, so that we can we can gauge how rational approaches are working.
Got it. So thank you very much for that. Wayne says prevention for long hauling condition.
Yeah, again, I think it goes back to thinking, we need to raise awareness, because I actually think it goes back to, as we're treating active COVID, thinking about what could result in a long hauler. And I think we've talked about that several times tonight, but I do think, is it because we're not treating long enough initially with all the various, COVID approaches? Do we need longer therapy? Do we need to have a therapy that you can use in the hospital and then you can use as an outpatient? But the bottom line is, I think whoever asked this question is beating up the right tree, because you know what? I think we're creating long haulers, and I think we have to understand exactly what it is that is inducing that. And I think the CD8 story is one of them, but there could be others. And we need to implement therapies that don't necessarily immunosuppress, but therapies that increase CD8 percentages as quickly as possible, and boost the immune system immediately after recovery. And then, but once you get to be a long hauler, it's not about boosting the immune system, because the immune system is heavily boosted. It's heavily, type 1 cytokine expression, which is, antiviral. And I think it needs to be cooled down. I mean, that's what's causing the symptoms. So it's not about immune boosting once you have a long hauler. There may be, some immune boosting to keep them from becoming a long hauler. So.
Got it. One more question. Eric the dog says, do long haulers suffer from anxiety attacks?
I wouldn't be surprised if they did. I mean, there's so much going on, and like I said, the response that they've gotten is anxiety inducing, among other things, anger, frustration. I mean, the emotions that we hear on the phone, they just come across on the phone. I mean, it's as if the patient's standing in front of you, because the frustration and the anger and the despair are so vivid. But the fact is, there's an end to this. I know there is. I know there is now, and there's light at the end of the tunnel.
Excellent. So, just a few more questions from the Twitter. Although, as we announced, and I just announced a day ago about your presence, and the whole Twitter thread has, I do not know, there are so many questions out here. So I'm going to very quickly see if I can ask you some questions from here as well. So, for example, have any long haulers had their symptoms resolved with treatment, and for how long? So I think you addressed it before as well.
I did, and the answer is yes. And the duration is variable. And I think we're still working on the duration of therapy. I think we've tried several different approaches, or many different approaches, to see if there is any response. I mean, any response is the first indication that you are actually targeting the right, the right combination of markers. And the fact is, with the long hauler index, we can see, after therapy, we're now doing before and after measurements to see how that changes the index. And I think having that capability has really helped us evaluate therapeutics. And I think one of the last questions is just how long do you treat?
Yeah, got it. Avox, who is a coffee bean as well. So we, in the cool bean group, we are various kinds of beans. So Avox is a coffee bean. His question is, do people who receive steroids to treat the initial active illness have more or less vulnerability to becoming a long hauler? Are there identified subtypes of long haulers?
Well, again, I don't think that first question has been answered because I don't think we have enough information on the initial course of disease and what therapies were given, if they were given. The second question, subtypes of long haulers, I don't think there's been two that have been the same in terms of their symptoms and their presentation. I think it was a miracle that, of course, we needed computer help, but it was a miracle that we found a common immune signature amongst all of them to monitor.
Got it. And Avox, you're a good friend of mine. A quick comment for you. In my management, previously I was managing more with the ivermectin and hydroxychloroquine, and I saw some people becoming long haulers. Nowadays, mostly those patients are reaching out to me who were being treated by someone else, and then they were becoming deteriorated. And one thing in common that I saw was that they were already put on the steroid from the day one. So one thing that I saw in them was putting them on steroid day one actually causes more issues because the virus, I think, has a chance to continue to replicate, immune system is suppressed. And because of that, they deteriorate more and then they are referred to me. At the same time, I also see that I have seen 0 long haulers from that group. That may be just a lack of correct sample size yet, but it seems like some early treatment with steroids is also helpful, but this is not scientific data. This is just my observation.
And I think high doses of steroids is not helpful. That's just my opinion from seeing how patients respond. Is these patients who have started with 60 milligrams. I don't think that's
dangerous.
No, that's not the right way to go.
Absolutely correct. Laura says, will the vaccine be helpful for long haulers?
Well, you've already had COVID, so the chances of you getting a vaccine, A, are very rare. B, I would not add fuel to the fire. Is my thoughts on this. I think the vaccine would be inducing the same thing that if it is persistent or residual COVID, the vaccine would be doing the same thing that's going on right now. It's causing all the problems. So no, I think it would be contraindicated, much like we contraindicate HPV vaccine in people who have had HPV.
Got it. Easy has a question. I have had 2 separate relapses, one quick and one a low-level struggle. Both may be triggered by chemical pollution, exposure to CS gas from crowd control agents and wildfire smoke. Sensical, are there clean areas and dirty areas where we have concentrations of long haulers? So any relationship to pollution and those things?
No, I mean, I don't. We don't have any information on that really, but I would say that anything that perturbs, the very fine regulation of our immune systems, whether it's allergies. I think there's some great data on mast cells and their release of cytokines in long haulers, and are individuals with pre-existing allergies more prone to long haulers. I think that goes back to the question about pre-existing conditions that might make create the long hauler symptom complex or make it worse. I think those are all good examples of pre-existing conditions that can exacerbate or lead to long hauler.
Got it. Next question is by Laura. And Laura, I would very respectfully request that we try not to give a specific patient's prescription opinion, because over here in this forum we do not have that doctor-patient relationship, and it is unethical for us to directly talk about a specific patient and their medication. So if you don't mind, I'm going to skip this question. I know what you're talking about. Maybe we can talk more in hypothetical at a later point. Laura's question is, would Plaquenil help me prevent COVID?
Prevent COVID? I don't know about that.
Cindy Glasgow says, how does COVID-19 affect the natural killer cell function? Does a loss of function play a role in the persistence development? If so, how can it be fixed? Can an underlying chronic bacterial infection like Mycoplasma pneumoniae cause viral persistence or reactivation?
Again, those are two very, very different questions. One is about natural killer cell function, and certainly natural killer cells are very important early on in COVID, in active COVID, and are intimately involved in the immune response against COVID. So I don't know about loss of function per se, and its relationship with long haulers, but they are another antigen presenting cell that could harbor the virus, so or viral proteins. So we have been looking at those as well.
Got it. So here is a comment that makes me feel like a celebrity. Holy smokes, you have Dr. Bruce Patterson on the show tomorrow. So just your presence makes me a celebrity as well. So thank you very much for your time. So Bite Twister, so he has some questions as well. Do you have any thoughts on long haulers being related to MCAS, macrophage activation syndrome, and does a low LH index score, so your, I think, scoring system, indicate being cured? Thoughts on vaccine triggering long haulers?
Yes. Well, again, vaccine itself is actually doing what it's supposed to be doing, which is the mRNA vaccines are getting into cells and producing viral proteins. And in fact, what they're trying to do is induce an immune response that's probably very similar, save for a few markers of what we're seeing in long haulers. But there's and it's probably why everybody has symptoms, days, after receiving the vaccine. So, I think that's an important question. We'll have to keep an eye on that. But there's obviously some other things going on in long haulers that are different from what the vaccines would be inducing. And yes, the long hauler index. So far, we've seen differences from individuals who've reported to have severe cases versus not so severe cases. And then thankfully, we are seeing individuals who we are treating decrease their long hauler index and come close to the cutoff point.
Got it. Thank you very much. Charla says, thoughts on fasting to trigger autophagy to recover from long COVID?
This isn't about that. It's about tempering the immune system and identifying and potentially getting rid of whatever the inciting agent is.
Got it. Corey, next question is by Corey. Corey, thank you very much. So both of those questions that you have, the ivermectin's role and then long haulers and vaccines, we just kind of addressed them a few minutes ago. So once again, thank you for your question. Mike Rossoft, why are my CD4 cells still low after 10 months? They're a bit higher than they were 4 months after infection, but still awfully low. Shouldn't they have recovered already? I don't know what my levels were before 6 years later. I wasn't 6.
Well, again, I think that the numbers that they have on screen, and again, I won't reveal those, aren't that worrisome. They're probably on the lower end of normal. And the fact that they are coming up is probably reflective of recovery. I mean, some of these immunologic abnormalities, depending on the severity of the initial COVID, just may not be coming back, that quickly. And, again, I think everybody's different, and you could probably put up 1,000 different stories here, and I think they all seem to make sense immunologically. And I think, like I said, now that we have the modeling to kind of link all of this together, I think we're in a better place in trying to use something that's been standardized to monitor them.
Got it. This list is long, so I'm going to ask a couple of more questions. Here we have Clifford Millington. I'm a long hauler of 9 months. Last blood tests showed high levels of monocytes and eosinophils. What is causing this? I did a 6-day steroid pulse in early November, which helped with some symptoms but never cleared all. Should I repeat this, and if so, for how long? So once again, the specific personal part is something that we cannot answer. But how about monocytes and eosinophils?
He just confirmed the paper we just submitted. So yes, indeed, monocyte elevations are, especially this one subpopulation, are, I would say, even universal in long haulers. And eosinophils, of course, are part of the sort of the allergic immune pathway. So I'm not surprised at that. So, and I'm also not surprised that you responded to steroids. I mean, again, I don't know if it's high dose or low dose, but the fact is that you got back to a better place, I think, is what's most important. And yes, I do think repeating is worthwhile, because it may take several times, if not continuous for a while. And that's why I'm promoting more low dose steroids for a longer period of time than these dose packs.
Yeah, and that is what I've seen with my patients. So again, not talking specifically for Clifford, but generally what I've seen is that if my patients had become long haulers, giving them low dose steroids, in some cases, more than one pulses has helped.
Yeah.
Ratchet Rave Roll, given all the blood samples you're collecting and the multitude of studies on long haulers happening at the time, within what time period do you expect some solid proof of certain theories being true or proven wrong within the next couple of weeks, months, next year?
Well, at some point I have to go home at the end of the day. But again, we're literally collecting data and writing papers and sending them in as fast as we possibly can. And thanks to individuals like Dr. Drbeen, we're able to talk about it, get the message out, share our findings in an open forum, even before they've been published, because I think there's just so many people going through this. And the bottom line is we're working as fast as we can, but I think the progress that we've made in 4 months is unbelievable. And I think I feel like we have our arms wrapped around it.
Got it. So as you can tell, there is a long list of questions, but I also know that we've been using your time pretty liberally as well. So how about for today, we close here, and then if you feel like it, we can come back to the discussion again, or people can reach out to Dr. Yo and you on Twitter. So thank you very much for your presence, for joining us. Any comment, any wrapping up statement for the long haulers, anything you would like to say?
No, again, I really appreciate you having me on, Dr. Drbeen. This has been a great mutual discussion, and I'm really happy that we're seeing some very similar theories and strategies in terms of treatment, because I do think we are heading in that direction. And your findings on low dose steroids as well as ours really gives me great hope. Like I said, I think it's a matter of finding the duration and being able to monitor it with the long hauler index and the other cytokines and or immune populations that aren't part of the long hauler index, seeing those resolve on an individual by individual basis. And like I said, once we have correlates with symptoms, I think, like I said, you have to understand it before you can, effectively treat it. And I think we have a really good understanding now. I'm to all the long haulers out there, I'm very, very hopeful. I have no doubt. There's a lot of doubts I have in medicine, and this is not one of them. I think, this is going to be treatable. I think this is going to be a situation where you can get back to where you were. How long it's going to take will depend on, on the appropriate therapies. But that's why we're setting up this long hauler, treatment center and diagnostics. So thank you, Dr. Drbeen, and thank you all the long haulers that have contributed to our study and all the information we had. We couldn't have done it without you, and we feel for you every day. Thank you.
So thank you very much, Dr. Patterson, for being here, and Cool Beans who are here and who will listen later on. There is hope. That is the summary for me. When Dr. Patterson said these are possibly fixable symptoms, these can be reversed, I actually breathed a sigh of relief. So I'm sure that when you heard it, there is hope for you as well. So let us continue to discuss these things. We will request Dr. Patterson and Dr. Yeo to come back here as well, or their team members to discuss further progress. We will keep you connecting to them as well. So with this, thank you very much for today, and see you tomorrow.
Thank you.